So thanks for joining us today. I'm Scott Podolsky, co-organizer with Carol Benoit and Jen Pusetti of our Social Medicine Seminar Series. For the past year, we've been balancing presentations on COVID-19 with those related to other aspects of social medicine and global health. And of course, the two domains not only frequently intersect, but are mutually informative. So along these lines, I'm honored to get today to introduce Neil Gupta, who will turn our attention to another present-day pandemic, namely hepatitis C infection. Dr. Gupta's biography is unique and certainly remarkably impressive. After receiving his undergraduate degree in neuroscience from Duke, he received his MD from Penn and received his MPH International and Global Studies from the Harvard T.H. Chan School of Public Health. Along the way, he would complete residencies in both pediatrics at Boston Children's Hospital and medicine at the Brigham through the Howard Hyatt program in global health equity. And like Dr. Gupta mentioned, we're honored to have Howard on the call with us today. Dr. Gupta has long worked on the intersection of poverty and both communicable and non-communicable disease, having served as Chief Medical Officer for Partners in Health in Rwanda, and more recently with folks like Jean Bookman and our department's program in global non-communicable disease and social change as the Policy Director for the NCD Synergies with Partners in Health and the Lancet NCDI Poverty Commission. He is presently an Assistant Professor of Medicine at Harvard Medical School, an Associate Physician in the Division of Global Health Equity at the Brigham, and an affiliate of our own Department of Global Health and Social Medicine. Perhaps most relevant to today's talk, Dr. Gupta is the primary investigator for the Simplifying Hepatitis C Antiviral Therapy for Elsewhere in the Developing World, or SHARED study. And he'll speak with us today on, quote, how a viral variant is threatening control of another pandemic, hard to treat hepatitis C genotypes in sub-Saharan Africa and their implications for global viral hepatitis elimination. So Dr. Gupta is going to get to speak for about 30-35 minutes. You're then all welcome to join in. You can use the Q&A function to bring in questions. If you'd like to actually speak directly, feel free to raise your hand and we can convert you over to a speaker. So it's my honor to get to hand this over to Dr. Gupta at this time.
Thanks so much, Scott. Very much appreciated. Wonderful to be with you all today. I was just telling Scott before we came on that I've given this talk before at the department on the first floor, and it was always a wonderful opportunity to connect with you all and think about overlap and synergies, potential connections in our research and our work. And I hope we can still do that in this virtual environment. So hoping that we can get into that in the discussion, but if not, also obviously afterwards over email and offline as possible. I'm just going to load my slides here. I hope everybody can see that. Carol, just let me know if for some reason that's not coming through. Great, thanks, Scott. So as Scott mentioned, today I'll be discussing a bit on our work in hepatitis C, work that you've all touched on perhaps or heard about in the past, and wanted to give you an update of where we stand. So today I'll be discussing three major areas. So the first will be to talk a little bit about the burden of viral hepatitis and goals for global elimination. Secondly, will be the evolution of hepatitis C treatment and feasibility of hepatitis C treatment delivery in sub-Saharan African settings. And then finally, some of our work on the threat of drug resistance in sub-Saharan Africa and implications this could have for overarching elimination goals in the region as well as globally. So really, if there's one slide that you'll remember from today, or that I hope you remember from today, I put it first and foremost up here up front to talk about the overall burden of viral hepatitis globally. So this slide, this figure shows from 1990 to 2017, global estimated deaths from different infectious disease conditions. And you can see here, malaria in green, HIV in red, tuberculosis in yellow. And you've probably seen that graph before, perhaps not with viral hepatitis superimposed. So viral hepatitis, namely chronic hepatitis B and hepatitis C infections, are the line in blue here. And as you can see, by 2017, the number of global deaths estimated from chronic hepatitis infection is actually eclipsing those of these other infections. Not only has it eclipsed, but it's on this upward trajectory. And I think this slide alone, where it stands, would be concerning enough. But if we project forward, you'll see that over the next 2 decades, there's really this tidal wave of impending deaths from chronic hepatitis B and hepatitis C infections that's coming down the pipeline. Very concerning, and obviously a call to action on viral hepatitis. A quick primer for those who might be new to hepatitis, just taking a step back. So viral hepatitis is actually a group of unrelated viral infections that have the common target of the liver, and really hepatocytes, or the cells that are in the liver. And they cause progressive fibrosis, or scarring down of liver cells over time. So you see that a normal liver can actually progress due to fibrosis to a cirrhotic liver, or cirrhosis, which means that a certain proportion of the liver hepatocytes are actually dysfunctional due to this fibrosis. And once you have a cirrhotic liver, that can lead to 2 major consequences. The first is end-stage liver disease, and that's when the majority of the liver is fibrosed and dysfunctional and not able to perform its normal duties in the body. And the second major outcome is hepatocellular carcinoma, listed here as HCC, or otherwise known as liver cancer. So those are the 2 serious major outcomes from chronic hepatitis infections. Liver cirrhosis has actually become the 7th leading cause of death worldwide, and is actually increasing globally across all regions. Hepatitis B and hepatitis C cause over half of deaths due to cirrhosis. Cirrhosis can also be caused by alcoholic hepatitis, as well as hepatitis due to fatty liver disease, which are increasing as well. Now, liver cancer, although it's not talked about so much, or you may not have heard about it as much as other cancers such as lung cancer or cervical cancer, it's actually the 4th most prevalent cancer worldwide. And if you look at it in terms of years of life lost globally, liver cancer actually results in the 2nd highest number of years of life lost due to cancers globally. So that speaks not only to the wide prevalence of viral hepatitis, but also to the severity of liver cancer and how it strikes at a fairly young age. Now, the overall burden of viral hepatitis and prevalence globally, I wanted to show you this map, and just to orient you to this map, these are the WHO subregions. The size of the circle is the number of estimated viral hepatitis infections in each of the subregions. The dark green is the proportion that's due to hepatitis B. The turquoise type green is proportion of infections due to hepatitis C. And this table on the right is actually the source data behind the circles that you're seeing. So 2 points I really want to bring out here. First is just the overall magnitude of viral hepatitis. So estimates are that 3.5% of the global population is actually infected with hepatitis B, and 1% of the global population is infected with hepatitis C. So we're looking at 4.5% of all individuals globally infected, or 1 in 20 with a viral hepatitis infection. So that's pretty staggering numbers if you think about it. The other point that I wanted to bring out here is just a difference between hepatitis B and C. As you can see, hepatitis B tracks with regional disparities. So we see high numbers of individuals with hepatitis B in East Asia, Southeast Asia, Sub-Saharan Africa, traditional regions with a high number of low-income countries or resource-constrained countries. Whereas hepatitis C is really everybody's problem. Hepatitis C has fairly equal numbers of estimated infections across regions. And hepatitis C tends to track more with local disparities, or inter-country disparities, rather than regional socioeconomic disparities. And we'll talk more about that and why that is in just a moment. So the good news and the very good news is that both hepatitis B and C are almost entirely preventable or curable, which is a really important feature when thinking about viral hepatitis and viral hepatitis elimination. So a quick primer to step back on both hepatitis B and hepatitis C for those who are new to these conditions. Hepatitis B, the primary mode of transmission globally is vertical transmission, so from mother to child, as well as in early childhood. And the progression to severe outcomes for hepatitis B is really age dependent. So that means newborns that are infected vertically, or children that are infected in the first years of life are actually have approximately 90% of them progress to severe life-threatening outcomes. Whereas if you're infected with hepatitis B later in life, it's less likely to cause severe outcomes. Now, hepatitis B, as most of you know, is fully vaccine preventable. So there's a childhood series, given at 2, 4, and 6 months of life. But there's also a birth dose vaccination given in the first 24 to 48 hours of life that can really prevent mother to child transmission, and has become the standard of care in this country and in many countries around the world. The other good news for hepatitis B is that rapid diagnostic testing is available, so it's easy to diagnose. And that treatment with readily available antiretrovirals that we commonly use in HIV, such as tenofovir, results in viral suppression of the disease over a lifetime for those that are eligible for treatment. Now, hepatitis C, on the other hand, some unique features. So the primary mode of transmission, as opposed to hepatitis B, is actually through bloodborne infections. So injection drug use is the primary cause of incident cases of hepatitis C in middle-income and high-income countries. And in low-income countries, due to unsafe medical practices, contaminated blood supply, unsafe injection practices, traditional practices are really the driver of hepatitis C infections in those settings. About a third of cases of hepatitis C can progress to severe outcomes. Unlike hepatitis B, there's no vaccine yet for hepatitis C. However, rapid diagnostic testing is available. It's easy to diagnose, and there has been a revolution in curative therapies for hepatitis C, so we can actually cure hepatitis C, and we'll talk much more about that in this presentation. So with that innovation and discovery over time, and with those abilities to prevent and treat these infections, there's been a lot of enthusiasm over the past 5 years or so for the potential to actually eliminate viral hepatitis as a public health threat over the next decade. So you see here, these are the global targets that have been established by the WHO and the global health community, which is really projecting out a 90% reduction in incidence of both hepatitis B and C, as well as a 65% reduction in mortality. So those are the targets that have been established as viral hepatitis elimination as a public health threat by the year 2030. So I told you the good news. Now we'll move on to the bad news. And the bad news is that very few people are accessing the fruits of that innovation and discovery over the past several decades in viral hepatitis. So very few people are accessing diagnosis and treatment. On the left here is the hepatitis B care cascade globally, and on the right is hepatitis C care cascade. And very simple: infection to diagnosis to treatment and suppression or cure. The dark blue are the estimated numbers, and the light blue are the 2030 targets that I just showed you. And you'll see for both B and C a huge number of estimated infections, about 320 million infections worldwide, but less than 20% of those are actually diagnosed, and less than 10% are diagnosed in the case of hepatitis B. And very minuscule amounts, you can actually barely make out a dark blue line there, accessing treatment for hepatitis B or C. And even fewer achieving suppression of hepatitis B virus or cure of hepatitis C in these two care cascades. If we look at the key interventions that are required to achieve elimination, on the left-hand side here, the first column are the core interventions that would be required. And out here to the right is our 2015 baseline in terms of coverage for each of those interventions, as well as the 2030 target to achieve elimination. And you can see across these interventions, and for particular interventions, the global community is quite far from achieving high coverage on the interventions that would be required. That's particularly notable for the birth dose vaccination, or prevention of mother-to-child transmission of hepatitis B. It's also quite notable in terms of harm reduction strategies or coverage of syringe and needle distribution globally. And then finally, towards the bottom here is the numbers that are diagnosed and treated. So people that are accessing rapid diagnostic testing, as well as suppression or curative therapies. And as you could probably expect, the African region, relative to other WHO identified regions, lags far behind on many of these indicators, not to mention the diagnosis and treatment that we were speaking about before. Today, we'll be focusing on one of these core interventions, and that's treatment for hepatitis C. And this number 2% that you see for that indicator for the African region is probably an overestimate. And it's also, just to point out, 2% of the 6% that are actually diagnosed. So we're talking about less than 0.5% or very minuscule numbers of patients that are actually accessing treatment for hepatitis C. So I'm going to shift gears here now to talk more about that particular story around hepatitis C treatment and some of our work on the feasibility of that in sub-Saharan African settings. So a quick timeline here on hepatitis C. Hepatitis C is actually has not been around for that long as far as that we've been able to diagnose. Hepatitis C was discovered in the 1970s, and the discoverers actually just received the Nobel Prize last year during the pandemic. It was a bit of a surprise, but we're really rewarded for the amazing discovery in chimp models in the 1970s and development of a test that could diagnose hepatitis C in the early 80s. In the 90s, we began screening the blood supply, so that began in 1992 in the US. But then we underwent a period of about 20 to 30 years where the only treatment available for hepatitis C was actually pegylated interferon and ribavirin. And for those of you familiar with it, that regimen was very difficult to take, 24 to 48 weeks of weekly sub-Q injections, very high side effect profile, very difficult to tolerate, and very low cure rates. So needless to say, it was very discouraging for populations that were already very hard to reach, that were being infected with hepatitis C, to come in, get treated, and actually achieve cure. So that culminated in 2013, 2012, 2013. I remember I was just finishing residency at the time, where the first all oral medications were becoming available. And this was really a treatment revolution. I think in health sciences in general, I think we very rarely see such a dramatic step up in prevention or treatment of a widespread condition. I think that might be second only to the COVID vaccinations that were developed over the past 12 months. So when in 2013, Sovaldi or sofosbuvir came online, and we started seeing the very high efficacy rates across genotypes and very low safety, very low adverse event profiles of these medications, there was quite a bit of enthusiasm and excitement around these drugs, also known as direct-acting antivirals, or DAAs. So over the course of 5 years, several companies produced regimens of DAAs, or direct-acting antivirals, that could be taken as one pill once a day for as little as 8 to 12 weeks across all genotypes, resulting in close to 100% cure rates. The pipeline for hepatitis C drugs is now dried up. So we've actually reached, I think, where the global community wants to reach in terms of effective and safe treatments. And the WHO has actually recommended 3 regimens as first-line therapy for hepatitis C globally. So no difference between high income and low income settings. And we'll talk a little bit about these regimens. I don't want to get too clinical in this presentation, but we'll talk a little bit about these regimens as we move forward. The other great news, not only this innovation and discovery, but the fact that the cost of production for these drugs is actually quite low. So there's There's no expensive ingredient involved in developing these drugs. And you can see with these two arrows, if we took a very common regimen known as sofosbuvir and ledipasvir, a first-line therapy used very commonly, the cost of producing those drugs as a combination for 12 weeks of therapy to achieve a cure is around $60. And that's an estimation, even including some profit margin, paying taxes on profits. So what a generic company could potentially produce those drugs for. Now the shocker, and I think you've all heard me talk about this before, is that when a drug like sofosbuvir and ledipasvir, otherwise known as Harvoni, hit the shelves in 2014, 2015, it actually was issued at a retail cost of $94,500. Now, to be fair, that retail cost was not actually the cost, the price that was being issued for the drug to many payers and providers around the world. But it was a cost that was intentionally, it was a price that was intentionally posted to recoup so-called research and development costs over time from the company that put it out, Gilead Sciences. So obviously this set off a firestorm of controversy in the global health community and amongst civil society. Patients living with, people living with hepatitis C were very upset about this, and the access restrictions that such prices would incur globally. We started writing about this, just thinking about the patients that we treat in PIH sites around the world. And thinking about how we could avoid potentially 20, 30 years of pain that we had to go through in the HIV epidemic to really gain access to such medications. So we started small at Partners in Health sites and thinking about what is the actual demand for hepatitis C treatment in some of the sites where we're working. And in Rwanda, we estimated that there was probably about 55,000 infections across the country. And we found that of those, only 253 were actually currently engaged in care in health facilities around the country. Only 92 had ever been documented to receive treatment in the past during the pegylated interferon and ribavirin days, and only 24 had documented cure. So these were, minimal or trivial amounts of numbers of patients compared to the overall burden of disease. And those that were actually engaged in care were coming with, obviously, with end-stage liver disease, hepatocellular carcinoma, or advanced fibrosis, and really advanced disease at the time. So with that, we started small. We established the shared study in 2016 to treat 300 adults with chronic hepatitis C infection for 12 weeks with the first-line therapy at the time, sofosbuvir and ledipasvir. Patients came from all districts of Rwanda, as well as from over the borders in Burundi, Tanzania, and Kenya. And we really just set out to document primary outcomes of safety and efficacy for this particular direct-acting antiviral regimen. So what we So what we found was what we thought we would find. We hypothesized that we would have a high cure rate and that these drugs would be safe and effective and easy to use, and that's exactly what they were. So we had an 87% cure rate amongst 300 patients. There was excellent adherence, high motivation amongst patients to complete the 12 weeks of therapy. There was no loss to follow up, high retention in care, and there were no serious drug-related adverse events. So overall, we were quite pleased at that time to have the results from this initial trial. We also were able to show in that initial trial that simplified treatment monitoring is also safe and effective. So the fact that you didn't need multiple CBCs and liver function exams and PCRs to track viral load, that it would be safe. We actually blinded clinicians to those tests in a group of patients, and we found that the patients in that group had the same cure rate, same safety profile, and same tolerability of their medications. And this simplified treatment monitoring is, through our work and others, has actually become the standard of care globally, not only in low-income settings, but in even here in the US. Additionally, the shared study showed that there were dramatic improvements in the quality of life for patients who were taking these medications. So from baseline to 24 weeks after achieving cure, this hepatitis C treatment resulted in improvements in physical quality of life, mental quality of life, and even down to the household's socioeconomic and social levels of improving food security, improving the reported ability to work, as well as significant improvements actually in the monthly cash earnings in the households that participated in the study. So this was quite dramatic. And our group of authors on this study that was led by members of our study team were really interpreting this to say that the return on investment case for investing in hepatitis C drugs for national programs in sub-Saharan Africa may be dramatically underestimated when you think of the social and socioeconomic benefits that are also obtained. So this study, the shared study with all of its findings, was thought of as the time as the first study to show that DAA treatment, or direct acting antiviral treatment, was safe and effective in a sub-Saharan African setting, and was really an advocacy push for the establishment of national hepatitis programs in Rwanda and beyond, and that this was feasible and possible. In parallel to this, there was a revolution in the prices of treatment as well, and that was primarily through two mechanisms. The first was that the direct pricing agreements. So the companies that were producing these drugs, there's three major companies, Bristol Myers Squibb, Gilead Sciences, and AbbVie, were actually going out to countries, payers, providers, and saying, hey, for a fixed volume, we can give you a discount on these drugs. And that's a very typical process for this type of medication. It culminated actually in this Netflix type subscription model where you could actually, a payer could pay a one-time fee every month and then have unlimited access to medications, really incentivizing getting treatment out to as many individuals as possible. So dropping the unit cost per patient dependent on how quickly you could diagnose and distribute hepatitis C medications. Many states in the US actually are functioning along those lines. Now, the second more dramatic mechanism for this revolution in treatment prices was an effort for voluntary licensing and generic manufacturing. So the companies that were producing these drugs, unlike during the HIV epidemic, really got ahead of this problem in defining a catchment area of low and low middle income countries, 101 countries in the case of Gilead, where generic manufacturers could actually produce the drugs in India. Companies in India could then sell them at a marked down price or a generic cost to those countries in this particular catchment area. So those two mechanisms together were very successful in driving down the price that countries such as Rwanda could obtain for these drugs and generic versions of these drugs, down from $1,000 per treatment course from the originator companies all the way down to about $60 of that production cost that we talked about earlier to treat patients in low-income settings. So that type of treatment revolution, or that type of and price reductions led to the establishment of many national hepatitis programs. Rwanda was really out front with developing a hepatitis C elimination plan and program over 5 years, established here at the end of 2018. You can see that IMB in Buzima really led the charge in supporting the Ministry of Health to establish this program. This picture is from a launch ceremony that was done in December of 2018, where you see Dr. Fred Katira and Dr. Joel Muligi speaking on this and supporting the initiative to move forward elimination, which was actually accelerated just before the pandemic, was accelerated from a 5-year plan to a 2-year plan. And there's been amazing progress in treating patients in Rwanda under this program. So I'll pause here and I'll say, this is where we actually thought the story would end. I think when we set out on the shared study in 2016, we thought that that would be really the story or the trajectory of the shared trial. But when we looked further into the data, we actually found an interesting sub-story here developing, and that was really the threat of drug resistance in the region and implications that that might have for elimination goals. So when we look closer at viral sequencing data of those 300 patients that were in the shared one trial, we found that the primary driver for treatment failure for that small group of individuals who did fail treatment was not adherence, but rather viral resistance. So in a group of individuals that had a particular genotype, subtype, so everybody in Rwanda has genotype 4, but within that, there's a list of about 15 to 20 subtypes of genotype 4. And in Rwanda was a circulating subtype that had not been previously described called genotype 4R. And we found that up to 15 to 20% of the population in Rwanda actually has genotype 4R. And those patients performed very poorly in terms of achieving cure. Only 56% of patients with genotype 4R achieved cure. That was the lowest rate of cure found worldwide for patients with high levels of adherence. And when we were able to sequence those samples from those patients, we found very high rates of resistance-associated substitutions or mutations to commonly used drugs such as ledipasvir or decladisvir, the first-line therapies that were accessible in the country at the time. All participants with genotype 4R had these resistance-associated substitutions in the key positions that would confer resistance to those medications. So this was a worrying development. Dr. Fabienne Shimbushu, who was our team lead for the study team for shared in Rwanda, and Dr. Ann Liu, a GI fellow at the Brigham, led a study to look deeper into the characteristics around those patients with genotype 4R, and we found that those patients tended to be younger, that they had higher baseline viral load, that they're more likely to have cirrhosis or advanced fibrosis, and that they did have a series of previous hospitalizations or surgeries, likely due to their advanced condition. Unfortunately, we did not find any particular hotspot of genotype 4R infections in Rwanda. It did not seem to be localized to one province or another, and it did seem to be spilling over the borders into surrounding countries as well. So obviously a very concerning story developing there through our prospective data in the shared trial. At the same time, there were study groups in Europe who were actually mining large databases of treatment failures in their countries to see what were the characteristics of treatment failure in patients that they were seeing. And these were large study groups in the UK, in Germany, and France. And what they were all finding fairly consistently is that there were high rates of treatment failures, particularly among sub-Saharan African immigrants with what they were calling rare or unusual genotypes. So this is a representative map from one of those studies where they listed out the high diversity of genotype 1 and genotype 4 from these sub-Saharan African countries, and the overall disproportionate rates of treatment failure in those subtypes, with genotype 4R being a primary culprit. This was, as you can see, diffusely spread across subregions, so everywhere Eastern, Western, Central, Southern Africa, all with high diversity, all with treatment failures. But genotype 4R really emerged as the subtype of most concern, really focused in that central Great Lakes region, all the way up to Ethiopia and eastern subregions of sub-Saharan Africa as well. So together with a group of hepatologists from countries that were host to some of these so-called rare or unusual subtypes, we put together a commentary really in response to this issue to shed light on the fact that these variants might be considered rare or unusual in high-income settings in Europe or North America, or clinical trials that were really the launch of these DA medications. But although these subtypes may be considered unusual or rare in those settings, that's not the case in large populations in sub-Saharan Africa. And we actually estimated that these subtypes probably predominate in some large burden countries in sub-Saharan Africa, such as Ethiopia, the DRC, Cameroon, Uganda, Rwanda. And we estimated in that paper that roughly half of all individuals with chronic hepatitis C infection in sub-Saharan Africa would harbor those subtypes. So overall, that would represent approximately 5.5 million infections, or almost 8% of the global epidemic is at risk for baseline treatment resistance. So this was obviously a major issue. It garnered a lot of attention in the hepatology community. And in 2020, just last year, there were finally updates to global recommendations where the European Society finally acknowledged genotype 4R as a major driver for treatment failure and made two recommendations, which I think are important. So here listed on the left side, they recommended that viral sequencing should be done in patients who are actually in endemic regions for genotype 4R, Central or Eastern Africa, or migrants from those regions who show up in Europe. The problem is, whereas viral sequencing might be available in Europe, it's obviously not routinely available for clinical care in sub-Saharan Africa. Furthermore, the guidelines said that such patients, or ones in endemic regions or migrants from those regions, should be considered for alternative drug regimens for those individuals, which is great in that we're not staying with failing regimens, first-line regimens that were recommended. But the catch is that there was no data on which regimen should be used and would be effective in these subtypes. So the question became, are there better treatments for subtypes such as genotype 4R? And here are two in vitro studies. One is Ladiposphere in the top figure, a pan-genotypic or a newer drug that could be used across all genotypes called Velpatasvir on the bottom. And in vitro data was actually showing us a lower EC50 or a lower effective concentration of Velpatasvir could actually be used against some of these subtypes. So our hypothesis here in a clinical public health setting is that sofosbuvir and Velpatasvir could be more effective in patients with these subtypes. So we launched another study, and we launched Shared 3 last year. We enrolled 122 participants in this study in two arms. One was a Velpatasvir-based regimen for first-time patients or first-line therapy, which was sofosbuvir and Velpatasvir, otherwise known as Epclusa, and a triple regimen known as Sof-Vel-Vox for patients who had previously been treated with direct-acting antivirals and had failed that treatment. That included patients from our first study who had failed the original therapy. We wrapped up those trials towards the end of last year. And although we're still in the data analysis phase, I can tell you that the preliminary results showed a very high safety and efficacy of these Velpatasvir-based regimens for both first and second line treatment. So that's promising. And the other promising news is that Velpatasvir, like the other drugs, has a very low production cost and is already being produced generically at a very affordable price. It's eligible under those voluntary licenses to be exported and sold in low-income settings. So that's good news at the potential for Velpatasvir regimens to be in sub-Saharan Africa, but they're nowhere to be found. And the challenges still exist in terms of pre-qualification for those generically produced drugs. So each generic company has to register those drugs, those drugs have to be reviewed, often through the WHO, and pre-qualified so that countries can begin buying them or procuring them. That the companies that are producing these drugs have not registered those products in low-income countries for lack of market or lack of demand. That there have been low order volumes from national programs and from countries in these settings. That those previous drugs, Ladiposphere and Declatosphere, really still dominate the market and have a fixed supply chain already. So those drugs continue to be used as first-line therapy. And then finally, when drugs are registered and are available in country, that there's significant price markups. So you can see here in this figure on the right, this is just an exemplary illustrative diagram, but shows the multiple stages at which there can be price markups on drugs, so that even if you have a low production cost, you can end up with twice that price, when it hits the shelves, and most of those costs being transferred directly to the pockets of patients with very little capital to actually invest in their own treatment. And I think we see that across diseases, HIV, TB, malaria, and others being no exception to those type of price markups. So obviously a huge problem here. So Partners in Health together collaborated and partnered with an amazing group out of New York called the Treatment Action Group, who many of you may know from HIV or TB, originally known as ACT UP, was a spinoff of ACT UP in the early 90s, and has huge advocacy reach. And they saw the central problem in this issue as well, and helped us put together a advocacy campaign and a series of policy briefs, really reaching out to those key players who can move the needle in making sure that patients in these countries with potential drug resistance can actually access the therapy that would be best suited for them. So there's recommendations here, a long list, but just to highlight a few. For generic manufacturers, those in India and elsewhere, to register these Vilpatasvir-based regimens for production in countries covered under voluntary license, and I should say for sale in countries covered under the voluntary licenses, that they should negotiate affordable pricing with national governments, regional procurers, and donors. And the recommendation to governments in these low-income settings is to support procurement of generic Vilpatasvir-based regimens and achieve a target price that is no more than, we estimated, $120 per treatment course at minimal or no cost to patients as a part of UHC or primary care or comprehensive packages of services. And then finally, to hepatitis programs out there, to really understand that genotype 4R and related genotype subtypes are a real problem, and that they really do need to confirm cure after initial treatment and provide appropriate second-line therapies or retreatment options to patients in their programs. I've had the fortune and opportunity of working with another organization recently called the Coalition for Global Hepatitis Elimination to really amplify this message around treatment resistance in sub-Saharan Africa and what we can do about it. And at the Coalition, which is the only viral hepatitis elimination focused organization or exclusively focused organization worldwide, we've set out with three major goals. So first, we're really setting out to convene a community of practice or bring stakeholders to the table to share best practices and initiatives for viral hepatitis worldwide, both hepatitis B and hepatitis C. Secondly, to create an evidence base and to put together the data that countries need in order to generate momentum and enthusiasm for viral hepatitis elimination. And then finally, to achieve commitments and mobilize commitments on both politically as well as financially for viral hepatitis elimination. One of the ways that we're doing that at the Coalition is really to push forward investment cases in hepatitis C elimination. And the fact of the matter is that hepatitis C elimination is not only life-saving, as I've shown you before, but it's very much cost-saving. So this work that was done by a group from the Kirby Institute in Australia 2 years ago shows what an investment case for hepatitis C looks like. You can see here across time on the bottom and return on investment on the vertical axis, the red line being a elimination level investment in global hepatitis, the gray line being the status quo. With elimination level investments, even though there would be a fairly large upfront cost, primarily due to diagnostics and treatment, within 10 years or at 2027, you actually recoup these costs. If you think about the averting health system costs due to morbidity and mortality of viral hepatitis, as well as the social and socioeconomic productivity gain by averting a huge number of new infections and mortality due to those infections. And you see that the return on that investment beyond 2027 increases dramatically because of the fact that this is a curative regimen, and we're talking about elimination. We're not talking about maintaining the status quo. We're not talking about containment or control. We're talking about real elimination here. You can see that the price tag for this is quite hefty, at about 4.8 billion per year at its peak in 2022. But relative to what we currently spend to maintain status quo and other conditions, it may seem like quite a good investment. Now, the WHO has looked into this as well in terms of benefits packages and how you deliver these interventions within primary care or within UHC. And diagnosis and treatment for viral hepatitis was initially left out of the UHC cube or the initial UHC package. So they went back and they actually did an analysis to say, if we added diagnosis and treatment to this UHC package of services that's being recommended, in addition to some services that were already included, such as vaccination for hepatitis B or harm reduction for hepatitis C, that it would incur approximately 1.5% additional investment on the overall package, but would result in a 5% decreased mortality and a 10% decreased morbidity over the course of 15 years. So finally, just a comment on COVID-19 here, and going back to Scott's original point when he introduced the seminar, is to say that over the past year, there's been estimates that delays or disruptions in routine health services due to COVID-19 has resulted in over 500,000 new hepatitis C infections and up to 72,000 excess deaths over the past year. So this is really the untold burden of the pandemic that's still ongoing and obviously accelerating in some regions of the world. The same group of hepatologists from around the sub-Saharan African region that commented on baseline resistance and the fact that these resistant strains are not rare or unusual, also came together to think about opportunities that the pandemic might present, such as shared vaccination campaigns for COVID-19 and viral hepatitis, safe injection practices or emphasizing safe injection practices using these vaccination campaigns, given the poor history of vaccination campaigns in actually disseminating hepatitis C in the past. And then finally, integrated PCR platforms. We've seen a real acceleration in COVID-19 PCR testing in many settings in sub-Saharan Africa. Not enough, but those that are could also be leveraged for viral hepatitis testing if and when the pandemic subsides in these regions. So I'm going to conclude there, and very much looking forward to your questions and comments, thoughts on and reflections on some of this work. Just to summarize, I hope I've really impressed on you the real magnitude and burden of viral hepatitis globally, and that this revolution in hepatitis C drugs has really given us an opportunity for viral hepatitis control and potentially elimination. That hepatitis C treatment through some of our work has been demonstrated to be safe and effective when delivered in sub-Saharan African settings with existing infrastructure, existing staffing, existing laboratory equipment, that this is really possible, but that a high baseline drug resistance in many of these regions where we're working really poses a threat to not only those treatment programs, but to global elimination. And I hope I've left you with a few specific actions that we feel could improve access to appropriate care and treatment for these populations so that we're not left with drug resistance issues and some of the challenges that we faced in the HIV epidemic decades down the road. So I'm going to stop there. A quick comment on just a memory of an individual that we lost in Rwanda, Dr. Patern Mizero. I think many of you know him. He was an intern at Rinkwavu with IMB and was a brilliant young doctor, very well loved around the country, who lost his life to liver cancer due to chronic hepatitis B infection that went undiagnosed. And in his final days was a huge advocate for improving testing and treatment. He lost his brother just shortly thereafter. So somebody to remember and really think about when we do this work. Thank you to all the shared study collaborators. Thanks to PIH and specifically Joya for really launching this work years ago. The division and Paul and Salman for being ahead of the curve on viral hepatitis. Thanks to the collaborators on the commentaries, the Treatment Action Group, and the Coalition for Global Hepatitis Elimination. So I'll pass back over to you, Scott. Thanks so much.
Neil, that was just a terrific and really important talk. So thank you so much. I ton of my own questions, but for our audience members, you can either put your questions in through the Q&A function, the chat, frankly, or if you want to speak directly to Neil, just do the hand raise function, and we'll we can make it available to come online. Neil, so first of all, it was just terrific, and as I was hearing you talk about this need to raise awareness and convince key players to quote move the needle, it seemed like there was this bit of catch up that was being played around raising the visibility of infectious hepatitis itself. And certainly, I think if you asked, this may represent my own myopia, but if you asked clinicians or even historians to rank HIV, TB, malaria, and infectious hepatitis and their role in the burden of disease, I think a lot of us would get that wrong. And I'm wondering why historically you think that's the case, why there is this need for this catch up around raising awareness.
I think that's a great question, and one that we've been thinking about quite a bit. I've been thinking about quite a bit. I think it's very clear the targets of viral hepatitis are, again, marginalized, neglected populations, right? So if we look at hepatitis B, who gets hepatitis B globally? Now, who's getting hepatitis B globally is, mothers and infants in East Asia, Southeast Asia, Sub-Saharan Africa. And those are populations without a voice. Those are populations that have traditionally been neglected or forgotten in global pandemics. Not that that's necessarily different than HIV, TB, or malaria. So it begs the question of why. I think the other point there is that hepatitis is seen as a chronic infection, and not all people progress to severe outcomes as they might in HIV. But that's the same case in TB. You know, there's this real silent majority of patients who might not progress, who might be living with that condition over a long period of time. And I think some of the challenges that the TB community faced as well. So I think there's a lot to learn there. I think for hepatitis C, I think we're looking at even more marginalized populations if we're thinking about prisoners, injection drug users, and those that are really affected by healthcare systems that have not been developed to the point where they can provide clean blood or injection safety. So these are populations without a voice, and ones that really need to accelerate. And I think this recent surge in enthusiasm is really a reflection on the innovation and discovery that's happened around hepatitis C treatment, hepatitis B vaccination, and hopefully moving towards a curative regimen for hepatitis B in the coming 5 to 10 years. I think that's right around the corner. Not to mention one other hepatitis that I didn't mention is hepatitis D. And hepatitis D, which tracks very closely with hepatitis B and worsens outcomes amongst those with hepatitis B, also has a treatment that's been FDA approved just in the past few months and will be scaled up in the coming years. So I think there's additional excitement with hepatitis B and hepatitis D cure coming. Hepatitis C vaccination is still an area for development. But I think all of those interventions combined can really push more momentum in thinking about viral hepatitis, not only the magnitude of the problem, as you mentioned, Scott, but the potential for elimination of those conditions in the years to come.
Thank you. Dr. Walegde raises a question which really gets at these issues of right now, the barriers to implementation of this plan that you outlined. He says hepatitis C treatment was initiated in Ethiopia, but became prohibitively expensive and lab monitoring became impossible. What should we do?
Thanks for the question. And I think many countries in the region are grappling with the same issue, is that there was excitement initially to attain drugs and diagnosis at a low cost, but it wasn't frankly sustainable over time. So it brings into question the financing. How do governments with limited resources, tax revenue, fiscal space into the future, afford these interventions moving forward? Even though by our standards they're very cost effective, it does still require initial capital to move forward. There's a few strategies that have been proposed and been successful in the past. One has been integration with other funding streams. So the Global Fund for HCV and malaria, it does recognize hepatitis C as a co-infection and has allowed for funding to be used in co-infected populations, and that has been leveraged for screening campaigns in places like Rwanda and others. So that's one existing funding stream. Other countries have had good success with obtaining loans through either the World Bank or other development banks to buy down some of the initial capital that's required to invest in hepatitis C or hepatitis B. Which we've seen as cost savings over time, but requires a huge political commitment from the top. And I think that's where successful countries have made their accomplishments, is really through high-level leadership, either from presidential offices, first ladies, or other high-ranking officials, to really stand behind hepatitis programming as a priority. And then finally, I'd say, thirdly, ultimately, there does need to be some prioritization or budgeting made for viral hepatitis within countries. So I think putting together that strategic information, putting together the real case of the burden of disease in country can really help viral hepatitis rise on the priority list in some countries that may have some ability to invest in some of the interventions required.
Thank you, Neil. And for folks, Neil, do you have to run now, or can you stay for a little bit longer?
Absolutely, I'd love to stay for longer.
Okay, great. So yeah, obviously we can stay as long as people want to, but let's plan on 10, 15 more minutes if need be. So along the lines of your last answer, Emily Rowe, who thought your talk was amazing, asked two really good questions. One of them was, which departments of ministries of health own this, and where does it fit within the Department of Planning priorities in your experience? Who on the ground is pushing for it?
That's a really good question. That's probably one of the limitations. Scott, to your point of there's a huge burden of disease. Why aren't we recognizing this, and why is this so poorly recognized? Viral hepatitis gets caught between quite a few of those vertical teams within ministries of health. Many see it as an infectious condition similar to HIV, and piggybacking on strong HIV programming, most countries will house viral hepatitis programs within HIV divisions and departments. But the huge burden of vertical transmission and the need for immunization has actually parked hepatitis B often in EPI programs or expanded immunization programming in places in sub-Saharan Africa. So it's a little bit in that maternal child health space as well. And then finally, an area that's very important to me and that we have a huge team working on is NCDs, and thinking about the long-term consequences of how do you manage this tsunami of end-stage liver disease and hepatocellular carcinoma is going to require clinical services at primary hospitals, at even down to health center level, of management of these end-stage consequences of liver disease. So it could be considered in many ways a non-communicable disease in terms of its end sequela. We actually did an analysis recently with Matt Coates and others on the line looking at GBD data, and it turns out that viral hepatitis is actually a primary driver for one of the major severe NCDs worldwide. If you think about infectious drivers of non-communicable diseases amongst the poorest populations globally. So great question, and I think it's fairly divided here. If I had to put my thoughts on that, on where to park viral hepatitis in ministries of health, I think the most success has come from well-capacitated teams that are dedicated to getting the supply chain out and the procurement of testing and treatment. So I think HIV does make a lot of sense. Also making sure that immunization programs are starting to introduce that birth dose vaccination and really leveraging some of the experience from HIV prevention and maternal to child transmission and really eliminating HIV maternal to child transmission. How can we do that also for hepatitis B?
Great. As a follow-up, second question to that, that was where it's this is macro, micro, or but we're local in the rural areas. What does the implementation look like? With which clinical team / program does this live, or could it live with somewhere within existing chronic services? And brought up HIV versus NCDs and how that's being implemented.
That's perfect. And I think just one thing to add on there, I think this challenge, if I can challenge everybody on the line, working in your own specific contexts, and I think many of us are health systems oriented folks, and thinking about how can we integrate key interventions, in that UHC cube that I was describing. Two major interventions that come to mind, and ones that we've been working on. The first is that birth dose vaccination for hepatitis B. If you think about it, this is the first vaccination that has to be given in a timely manner between 24 to 48 hours of life. And it is quite difficult to deliver in rural settings where the majority of women in the region deliver. And so that has been a major challenge. And I think there's a lot of operational research, a lot of implementation science to be done there. How do you do that for home births? How do we do this at rural facilities? How do we maintain cold chain for such vaccinations? How do we ensure vaccination safety for newborn infants? Is a huge area of concern and interest, and I think one that we should be pushing programming for. Gavi has recently included hepatitis B vaccination in its priority areas, and hepatitis B vaccination at birth is actually quite affordable, but all of the infrastructure that's required to deliver that birth dose immunization is an area of focus for the coming years for Gavi, and we'll be supporting countries to figure out that infrastructure over the coming years. The second intervention is diagnosis and screening. So you saw that huge drop off from these immense numbers that are estimated to be infected to those that actually know their diagnosis. So why do less than 10% of people know that they're infected with hepatitis B? It's really just astronomical when we have rapid test strips that could be used for initial diagnosis, and then confirmation that needs to be done on PCR platforms. So this is an area that actually the COVID pandemic may actually support or help viral hepatitis programming, is if PCR platforms become more available, and this includes GeneXpert for the TB folks out there. If they become more accessible, more available, and we can build the case of integrating across diseases to really fully utilize those testing platforms, that could be an opportunity to improve not only screening, but actual diagnosis of both hepatitis B and hepatitis C. So thinking through the specific interventions, I think is really important when we're thinking about expanding coverage for these services and improving that care cascade.
Great. Well, Neil, this was just a fantastic talk, fantastic presentation, and really thoughtful answers. I learned a great deal. I suspect everyone else did as well. So thank you very much. Great, and certainly to our audience members, thank you very much as well. And obviously, right to Neil with any other questions you might have. But
thanks so much, Scott, and I hope to hear from everybody. Thanks for the time, and looking forward to further discussion at some point. Appreciate it.